Thank you for joining me. I'm going to talk about PTEN deletions and clinical outcome in prostate cancer. I'm speaking to you from Queen's University in Kingston, Canada. Now, one of the consequences of early detection for prostate cancer by public health PSA screening has been that since the 1990s, something like 90% of men are now diagnosed with much earlier prostate cancer. So they have smaller tumors and localized disease, which is good. Unfortunately, such localized tumors are actually quite diverse, ranging from fairly clinically indolent tumors to a smaller subset of about 20% that have more aggressive behavior and a high potential for recurrence and metastasis. So these are the bad actors and the ones that one wants to identify and manage in a slightly different way. Now, this is a typical presentation of prostate cancer in the post-PSA era, and this is a whole mount section of radical prostatectomy, and it's obviously you can see to the top right I've marked a red rectangle where there's a small area of tumor. This is a Gleason 7, so it comprises Gleason 4 in red and Gleason 3 in the turquoise color. There are also some areas of what are called PTEN, which I'll come back to later. Now, when you're looking close up at this area, you can see that this is actually a good side of early detection. So although this tumor is small, it's very close to the capsule. Unfortunately, it was detected before the tumor spread outside the capsule of the prostate gland. So this is good news. Now, we became interested in PTEN because it seemed as if it was really a very important biomarker in prostate cancer oncogenesis. And historically, PTEN had been considered to be a fairly late change in prostate cancer. Now, the gene itself is a phosphatase, and it's encoded by a gene on chromosome 10. The phosphatase is involved in cell cycle regulation, and it controls some fundamental signaling processes related to growth, rapid cell division, ability to differentiate, and so on. And it's a tumor suppressor gene, so in the classic way it's inactivated by loss of function, so this is by deletion or mutation. In prostate cancer it seems to be mostly by deletion of the whole gene. How does the gene work? Well, when it's functioning normally, the protein acts as part of a cellular pathway that tells cells when to stop dividing, and so it causes cells to enter apoptosis, this natural cell death pathway, when sufficient cell growth has taken place. Loss of this sort of critical regulatory functions engendered by loss of PTEN or by deletion of PTEN can lead to uncontrolled growth, and this of course leads to tumors, not only prostate cancer, but it has been associated with other types of tumors as well. So there's evidence that the protein is needed also to stabilize DNA, so it seems to have a role in DNA instability, and it's also downstream signaling directly regulates cell movement and migration and adhesion, things that are related to metastatic properties of cancer. So it clearly is a very important protein and acts on a very, very important pathway. We first became interested in PTEN when we started doing a study looking at matched prostate cancers and PIN. So these were radical prostatectomies in which, in addition to tumor being detected, there was also evidence of prostatic intraepithelial neoplasia. And this is a lesion that's considered a precursor lesion for prostate cancer. And you can see underneath there that those sort of point here, you can see this is an area of PIN here and here. And so the assay that we did was a two-color fish assay, and the centromere is green and the PTEN gene is red. And in some high-grade PIN, we noticed loss of the PTEN gene. So there's only one red spot here and here. This is a normal PTEN in prostate cancer, so this is prostate cancer which has normal copies, and this is deleted PTEN in prostate cancer, has lost one copy. And so in fact, in summary, we found something like 3 out of the 13 high-grade PIN had lost one copy of the PTEN gene. In addition, 22 out of 35 of the prostate cancers had lost one copy of the PTEN gene, and 2 out of 35 had lost both copies of the gene. So this was important evidence that PTEN had a role in prostate cancer. We didn't have any clinical information associated with this particular cohort. So one of our collaborations about a year later involved a group of over 100 men where we had, in addition to clinical information at the time of radical prostatectomy, follow-up data, particularly time to PSA recurrence. And so this describes the cohort. About half of them had biochemical recurrence as measured by BSA, and then PSA, sorry. And then this is the distribution of pathology stage and Gleason scores. And the assay itself, again, is similar to what I just showed you, a two-color FISH assay. And you can see that 60 out of the 107 tumors had normal copies, 2 copies of PTEN, as shown by red here. 42 out of 107, that's 40%, had lost one copy of the gene, and 5 out of 107 had lost both copies of the gene. When we looked at the distribution in biochemical recurrence, you can see that there's enrichment of the group that have lost PTEN in the patients that recurred biochemically. Compared to the ones without biochemical recurrence, you see PTEN is much lower there. And this is more apparent when you do a Kaplan-Meiers of time to biochemical recurrence. And you can see that this axis here, this very sharp axis, is the 5 patients that had lost both copies of the PTEN gene. This group of 42 patients had lost one copy of the PTEN gene, and the 60 with both PTENs intact are shown here. So this was very interesting and very promising data. These are the hazard ratios. You can see that hemizygous PTEN deletion is comparable to unfavorable surgical margins such as seminal vesicle invasion, extracapsular extension. Homozygous deletion has a hazard ratio of 11.2. Interestingly, in this cohort, we had 10 patients where we had a primary adenocarcinoma and a matched regional lymph node metastasis. And when we looked at the status of PTEN, overall 9 out of 10 of these tumors had lost a PTEN, so 90% having involvement of PTEN loss. Hemizygous PTEN deletion in 4 out of 10 of the matched pairs. Homozygous PTEN deletion in both the primary tumor and the accompanying metastatic lymph node in 3 out of 10, and importantly 2 out of 10 tumors with a hemizygous PTEN deletion in the primary tumor had an accompanying positive lymph node biopsy that had acquired a second loss of PTEN. So it looked as if transition from hemizygous PTEN to homozygous PTEN occurred at the time of metastasis in these patients. So this was very compelling finding. We were very pleased when a paper came out from the Marsden group in the UK last year, British Journal of Cancer, where they had a slightly different cohort. So these are patient tumors where they've done FISH on prostate cancer identified in patients with TERP, tumor in TERP, transurethral prostatectomy sampling. And they found that PTEN deletion was associated with time to death, so it's a mortality. So you can see that this line here, hazard ratio of 4.8, are the patients that their survival from prostate cancer after diagnosis here. So, and this is the patients that didn't have a PTEN deletion here. So this again shows an association with PTEN loss and survival. And in this study, they also looked at other markers, the well-known fusion gene, which is called TMPRSS2 with ERG or ETV1, and in fact they found that this blue line here is a tumor. The blue dotted line is a tumor with PTEN loss but normal ERG rearrangement by FISH, and in fact this line here is PTEN loss with a rearrangement. So it looked as if the single worst thing in this comparison was loss of PTEN and survival. So PTEN seems to be very important. That was the conclusion.